Hello everyone, welcome to another video on my channel, and on this one we'll be discussing most commonly encountered skin lesions that we come across in dermatology. So here I've got a question for you, and you don't even have to read the history. Just by looking at it you can make a spot diagnosis and know what it is. So just go ahead and give it a try. So what's the answer? It's herpes zoster. Yeah, that's right. So like I told you, it's very easy. Right. So, but still, I don't think it's good enough to just know the answers to questions sometimes. As medical students, we have to have a very thorough background knowledge about these commonly encountered topics. So let's go ahead and try to get a better understanding about these medical conditions. Alright, so first term is herpes zoster, which is the answer to the question. But I think before talking about herpes zoster, we have to talk a little bit about chickenpox, because without chickenpox, there is no shingles. Chickenpox is like the mother of shingles. Alright, so what's the common etiology for both these conditions? It's varicella zoster virus. So initially, when a patient is infected with um, this virus, they'll be initially developing primary varicella zoster infection, which is also called as chickenpox. So initially this has an incubation period of around 12 to 20 days, which will be followed by a prodrome, which has malaise, fever, headache, myalgia, and about 24 hours after this, the individual, the affected, will be developing a widespread rash, which is typical of chickenpox. So this rash, it initially starts in the head and trunk area, and gradually over the days it will be progressing into the peripheries. So generally, initially it will come as papules, and then later or after a few days develop into vesicles and then pustules, especially if children scratch these vesicles because they can be very pruritic. But then they'll cause pustules and later scarring, so it's not a good thing to scratch. And then at the end of it, about 5 to 7 days, these lesions will be crusted. Um, so yeah, but it doesn't necessarily follow this kind of order. What I mean to say is, at any given time, the patient can have all stages of these lesions happening at the same time. So it doesn't follow one after the other like this. But there is an important clinical point to mention here. That is, while the patient is having this rash in the body, the patient is very contagious, and very infectious, and they start becoming infectious after these lesions are crusted. And also, even during the prodrome period, that is 24 hours before they develop the rash, still they are infectious even during the prodrome period. Alright, so let's talk a little bit more about the natural history of the illness. Generally, like I told you earlier, if children are affected, which is the most common case, they resolve on their own. It's a very self-limiting infection, and in this case, what they have to do is during the time the child is very contagious, the child should not go outside or to nursery, and they should preferably stay at home, and they have to be kept well hydrated and have to rest, and these lesions will resolve on its own, and it's not recommended to give any antiviral medication to these children. But however, if an adult is infectious with chickenpox and they have developed the rash, they can have severe kind of illness, so that we always have to remember, because these adults might need IV acyclovir, and also they might develop complications like secondary bacterial infections, encephalitis over the weeks, disseminated disease, especially in immunocompromised individuals and elderly, and also very rarely they can have purpura fulminans, which is a necrotizing skin lesion. Right, so like I told you earlier, in children it's a self-limited condition, so we don't generally treat them, we just give supportive symptomatic management. However, in adults, generally if they're presenting with the rash, we treat them with IV acyclovir. to prevent complications. And also there's something called post-exposure prophylaxis, which is generally given to immunocompromised individuals, for example, individuals who are having chemotherapy, pregnant women and newborns. So what do I mean by post-exposure prophylaxis? Uh, because these individuals cannot mount a good enough immune response, we give them human varicella zoster immunoglobulins, but this has to be given within 10 days of exposure to chickenpox virus for its optimal effects. Right, so at the same time, if the adult is immunocompetent, which means they can mount a good enough immune response, in that case, we don't have to rush and give them immunoglobulins, which we can just go ahead with varicella vaccine, which has to be again given within 5 days of exposure. Right, so here itself, I'll try to tell something really quick about the vaccine, varicella vaccine. So this is generally given as 2 shots, and it can be given to children or adults. And it's generally the first shot is given, and then after 6 weeks, the second shot is given as a very safe vaccine. It can have like mild side effects like pain and tenderness at the site, and sometimes rarely anaphylaxis, and very rarely these individuals, after giving vaccine, they can develop a mild version of chickenpox, which is about less than 1% of the population. So it's worth getting the vaccine than getting the disease, you know. And also important for medical students to remember that because it's a live attenuated vaccine, we do not generally give it in immunocompromised or in pregnant women. Right, so we have discussed about the initial presentation, that is chickenpox, which is caused by the virus. And then what happens is the virus goes and lie dormant in the cranial nerve ganglia and also in the dorsal root ganglia. So it's affecting and lie dormant in the nerves. So later, when the patient is elderly and immunocompromised, they are reactivated and it causes shingles, also known as herpes zoster. So this is the typical presentation of herpes zoster. As you can see on the right side, it shows the dermatomal distribution. Here it's the ophthalmic branch of the trigeminal nerve, and in this case, shingles is appearing in this dermatomal distribution of the face. And on the left side, you can see shingles occurring in dermatomal distribution of the thoracic region, which is probably coming from the dorsal root ganglia. Here are some visible lesions similar in picture to a chickenpox, but it's restricted to one particular dermatome. And also characteristically, it has an erythematous base, vesicular lesions coming in a particular dermatome. And also this can even affect the eye, it can affect the facial nerve, in which case we call it as Ramsay-Hunt syndrome, and they can present with Bell's palsy, not really Bell's palsy, but facial nerve palsy. So those are the classic clinical presentations of shingles. And yes, but these patients, even before developing vesicles, they can present with intense local pain, which is a classic of shingles. So these patients have to be diagnosed as soon as possible and treated with antiviral medication, which is acyclovir, and it's shown that if it started early, preferably within 72 hours of exposure, it is shown to slow the disease progression and the severity of the illness. So we give it as soon as possible. But they can later on develop a complication called neuralgic pain, which is a very severe shooting type of pain in the affected dermatomal distribution, and this can be treated with SSRI, antidepressants, or gabapentin, or simple analgesics, but it generally does not respond to simple analgesics, so gabapentin is needed in most cases. Alright, so that was the obvious answer for the question, and we have discussed it in great detail. But also, one stem was impetigo, and I thought of just giving you one slide explanation on impetigo. So it's a skin lesion caused by Staphylococcus or even Streptococcus in some cases, and it most commonly happens in children. Generally, uh, uh, these happen, these lesions come in children who have pre-existing skin lesions like atopic eczema, for example, and initially they come as vascular lesions, which later on rupture and release this exudate into outside, which will later on um, form a crust, which is very characteristic, honey-colored in appearance. And what you have to remember is that these lesions are very contagious, so the child should stay at home preferably, and this has to be treated with topical antibiotics. These lesions appear in face and neck and hand, but unlike in herpes, it's not restricted to any dermatomal distribution. As such, it can just randomly appear in anywhere on the face. So yeah, so with that we come to the end of this very easy questions. I hope my discussion helps you fill gaps in your knowledge, maybe if there were any. So if you have any questions, more questions related to this, fire away and share it with us in the comment section. And also if you have any suggestions to improve my presentations or discussions, you can also share it in the comment section. So yeah, see you in my next video. Thank you for joining us. See you. Bye.